We'll start this chapter with some basic facts about childhood growth. The newborn loses about 10% of the birth weight in the first week of life, which is perfectly normal. However, this should be regained or surpassed by about 2 weeks. If this doesn't happen, that's the abnormal situation. And then the infant doubles the birth weight by 6 months and triples it typically within the first year of life. Growth of the first years of life is relatively rapid and linear, and then between 6 and 12 years of age, there are 3 to 6 individual growth spurts each year. Myelination is completed by 7 years of age. And then between 10 to 20 years, we have the adolescent growth spurt, followed by slowing down and eventual closure of the epiphyses. In boys, the adolescent growth spurt peaks at 13.5 years. Epiphyseal closure is 18 to 19. And in girls, this is a little bit earlier. 11.5 years is the peak, stopping at 16 years of age. In assessing growth, it's imperative that every pediatrician or any physician taking care of children carefully measure height, weight, and head circumference for the first 3 years of life, and height and weight during every single well child care visit, and plot it appropriately on the growth chart. So the growth chart is the best tool to determine whether a child is doing well with respect to growth, that is, has a normal growth velocity and increasing steadily over time, and also to determine whether a child is of average height, low height, that is short, or tall stature. There are separate charts for boys and girls, and they are divided from 0 to 3 years of age, and then 2 to 20 years of age, so between 2 and 3 is an overlap, and you can either finish on the 0 to 3 year or start the 2 to 20 year at age 2. The charts measure weight for age, height for age, head circumference for age, weight for height, and body mass index. Increase in height over the first 2 years of life can be somewhat variable, reflecting the intrauterine environment and the situation at birth. However, by age 2, height is fairly stable, and generally the percentile that the child is on at age 2 correlates with the final percentile and therefore the final adult height. Generally, children from age 2 on up should not cross more than one major percentile up or down in terms of ultimately staying on those percentiles through epiphyseal closure. Very low birth weight infants, low birth weight infants generally have some catch-up growth at least by about age 2 years of age. And weight to height less than the 5th percentile is the single best indicator for acute malnutrition, whereas the body mass index is the best clinical indicator for overall underweight and overweight, that is childhood obesity. If we want to measure patterns of growth in terms of why a child is tall or why a child is particularly short, then the best initial test, the most accurate test, is taking an x-ray of the non-dominant, which is usually the left hand and the wrist. And the radiologist reads this, looking at the epiphyses, and has a book for comparison, standards, so that the epiphyseal development in the child in question on the x-ray can be matched to the standards, and the radiologist can determine a bone age. Now, bone age in almost every single child is exactly what it should be in reference to the chronological age of the child. That is, it advances per the chronological age. In certain situations related to short stature, however, the bone age may be delayed, and less commonly in situations with respect to very tall stature. More importantly, stature that is getting tall really quickly would be an advanced bone age. Disorders of growth can be classified as you see on this chart. We can look at either problems with respect to height or weight. Height problems are either short stature or tall stature, whereas with weight we have failure to thrive due to organic problems, specific diseases, failure to thrive, which is non-organic, which is the vast majority of children with failure to thrive, or childhood obesity. So a brief summary so far is the most important evaluation to make is the actual growth velocity. That is the point-by-point increase between 2 points on the chart between any 2 ages should be such that the points are going upwards following the pattern of the growth curves that are drawn on the growth charts. And this is called growth velocity. And if it keeps going up and up and up, that is, if the point-by-point increase is such that the curves are going up, the patient is getting taller each time, we say that the patient has a normal growth velocity. And this should then follow, as I said, after age 2, one growth curve with little deviation, not more than one major percentile either down or up, until the time that the child is finished growing and the epiphyses have closed. Remember again that chronological age simply refers to the actual age of the child, so that if the child has his 5th birthday today, he's 5 years and 0 days old, whereas the bone age is determined by the X-ray and is the best initial test, the most accurate test in terms of determining specific etiologies and particular problems with respect to growth. So we can look at growth as then being normal, having normal growth velocity, or abnormal, that is having an abnormal growth velocity, in relationship to where the bone age is compared to the chronological age. Again, the normal situation is that chronological age pretty much equals bone age, and as you can see in the left-hand column that says normal, that is a child who's growing normally, a child who has a normal growth velocity. This is the physiological ideal situation, which occurs in almost all children. On the other hand, if a child has a genetic abnormality, a chromosomal abnormality, and is short because of that, then because this is still genetics, it's the genetics of the child, even though it's abnormal genetics, it doesn't matter. The body basically looks at this and says that the chronological age and the bone age are still going to be the same. On the other hand, if we have the most common problem with respect to growth and short stature in children, which is called constitutional delay, and we will discuss this further, then if we were to check the bone age, we would see that it was delayed or less than the chronological age. Whereas in children who are obese, who often are tall as well, or in children who are part of families that are all tall, familial tall stature, then the bone age is still either close to where it should be compared to chronological age, or slightly advanced but not greatly advanced compared to the chronological age. On the right-hand side, the abnormal situation again means abnormal growth velocity. For some reason, the child's growth curve is not following the normal pattern of going up and up and up in the way that it does for the normal growth curves. So in the first line, again, we have a situation where if we were to measure bone age, we would find that it is roughly equal to the chronological age. And if we have abnormal growth velocity this time, then this is genetic causes of short stature. If the bone age is delayed and the growth velocity is abnormal, then we have the 3 major topics in this category. The child either has a chronic illness, a nutritional deprivation, or an endocrine-related problem with respect to growth, and these are basically 2, and that is short stature because of growth hormone deficiency or hypothyroidism. And finally then, in cases where the bone age is significantly advanced compared to the chronological age, we have a number of different problems, some of which, just as examples, are listed here. Precocious puberty can do this, congenital adrenal hyperplasia, primarily the 21-hydroxylase deficiency, causes of hyperpituitarism, and rarely certain syndromes.
A father is worried that his 13-year-old son is short. The child has been very healthy. He is below the 5th percentile where he has been all of his life. Physical exam is normal. Father is 6'4", mother is 5'10". Father was a late bloomer.
So before we go into the first growth abnormality, which is reflected by that vignette, let's just look at a normal height set of growth curves which we see here. Now, this is not the real situation because on all growth curves, both the height curves and the weight curves are drawn on the same curve. For simplification, we've just removed the weight curves just to focus in on the height. So again, the shape of these curves is reflecting the way that children grow in the United States based on the basic facts that I gave you at the beginning of this section. You can see that the middle point, the heavy point, represents the median at all ages, the average roughly about the 50th percentile. You can see out to the side. On the right it says 50th percentile, where all of the lines below that are decreasing percentiles down to the bottom line, which is the 3rd percentile, and above it up to the top line, which is the 97th percentile. So obviously, as the child gets further on the growth curve closer to the lower line, he's getting shorter and shorter and shorter. And if his growth is below the 3rd line, we say that he has pathological short stature. Whereas if he is tall and he's moving up above the 50th percentile further and further and further, he's getting taller up to the 97th percentile. Now, the percentiles, just per basic statistics, obviously will get less and less and less as we get away from the median. In other words, a child who is then growing on the 3rd percentile, we can say is short because at whatever age that he's on the 3rd percentile, he or she is only taller than 3% of children at that age of the same sex. Whereas if a child, boy or girl, at any age is on the 97th percentile, then we can say that they are particularly tall because at that age for their sex, they're taller than 97% of all children. In other words, only 3% are taller. So again, as we get closer to the top and the bottom, then we are at the third percentile ends of each of these. Only 3% of the children below the third percentile, only 3% above the 97th percentile. So the largest grouping of children, as usual, is going to be in the middle around the median, with smaller numbers of children going out and out and out as we approach the limits, third through the 97th percentile. As stated, the most common condition that we see related to short stature in childhood is constitutional delay. Now, what is constitutional delay? I think that this graph depicts it perfectly. Constitutional delay is a situation whereas during pre-adolescence, and you can see this on the child's red growth curve, that is up until about the age of 11 to 12 roughly, this child is growing along the third percentile. So he has short stature, and this is typical of constitutional delay, but he is growing along the third percentile. So at that point, from age 2, the bottom of this growth curve, up until about 11, when he starts to deviate, roughly 11, a little bit before that perhaps, then he has a normal growth velocity because his growth is going up and up and up along the third percentile. But being along the third percentile makes him relatively short. Now, after that, you can see exactly what happens and what will be the definition then of constitutional delay. Constitutional delay then means you have a delay in the adolescent growth spurt. If you look at the child's red line compared to the rest of the curves, the normal curves, which are printed on the page, you can see that typically at around 11 or so years of age, we have the beginning of the adolescent growth spurt. And if you look at that between ages 11 and 15 to 16 roughly, you can see a huge increase in the slope, a normal huge increase in the growth velocity, again representing the typical adolescent growth spurt, with the child advancing through the various Tanner stages because of pubertal development at that time. In the child with constitutional delay, though, because that doesn't happen, that child's growth curve will just continue on linearly, as you can see it's doing. It's moving further away from the bottom of the growth curve, becoming now clearly abnormal with respect to growth velocity. So the abnormal growth velocity in children with constitutional delay occurs simply because they are not having their adolescent growth spurt at the normal time, but it's being delayed until a later time. And you can see again in this particular child when that occurs. He starts to have significant catch-up growth now at about 16 to 17 years of age, so that the slope now starts to increase significantly, and he moves well back up under the growth curve again until he flattens out like he should, because adolescent growth is going to slow down and epiphyses are going to close. So those are the characteristics of constitutional delay. In addition to a delay in the adolescent growth spurt, that is with respect to growth, the child will also have a delay in the development of pubertal changes, that is a slow progression of Tanner stages. So both occur together, and those are the keys to making this diagnosis long run. However, because we're going to be evaluating most children in the prepubertal area, in the lower end of the growth curve, where the child has a normal growth velocity and is short, then because this child's history and physical is going to be completely normal, there's not much help thus far that we have in calling this constitutional delay. So what you typically have then, and what is helpful in making the diagnosis, is you'll hear from the mother or the father that when they were young, they were short, but they were growing. They had a delay in their adolescent growth spurt, and they had a delay in their pubertal development. So in other words, as the father said in the vignette that I read, they are late bloomers. And now when you put that together, you realize that inevitably this is the case in this child as well. So what you can tell them is, like you, Dad, remember the father in the example currently is 6'4", so he obviously had a significant amount of catch-up growth and grew, and in fact is very tall. We can say that this child will eventually have significant catch-up growth, and his end height will be pretty much very close to or at where it should have been had this not happened. And if it's a boy, his height will approach the father's height, and if it's a girl, the height will approach the mother's height. And we can actually predict that with a little arithmetic formula, and this is called mid-parental height. If we look at this purely with respect to the bone age and the growth velocity, then, if we were to do a bone age, which as long as we have the family history, as I said, and is strongly suggestive of the diagnosis, we don't need a bone age, it's a wasted test. The only way you would need to do that is if you don't have any other indication of the possible diagnosis, meaning you don't have the family history. Because now all we have, again, is a normal history, a normal physical examination, and a child who is growing with a normal growth velocity but is short. So if we now do the bone age, we'll find that the bone age is delayed with respect to the chronological age. Now, on this curve in red, the chronological age and the bone age relationship simply written backwards. To say that the chronological age is greater than the bone age is the same as saying, of course, the bone age is less than the chronological age. In other words, the bone age is delayed. And this is good. Anytime we have a child with short stature where the bone age is delayed, then that is what is going to allow for the possibility of catch-up growth, because that means that the epiphyses will stay open that much longer. For instance, if we find that the bone age is delayed by 3 whole years compared to the chronological age, then we get a 3 whole year period of catch-up growth where the child can now start accelerating, move back on the growth curve until finally he starts to flatten out and his epiphyses close, which is why his ultimate growth is still going to be close to normal, which is going to be predicted by the mid-parental height. Any reason for nutritional deprivation, either not giving food and therefore having low calories, or not assimilating the calories because of a disease state, or loss of calories because of malabsorption and diarrhea, vomiting, and or any chronic illness that is going on without a diagnosis, that has certain signs and symptoms associated with whatever that chronic illness may be, that eventually gets to a point where now calories are taken away from the child. First, the weight starts to slow down. So we have a slowdown of the weight velocity. And if that then continues on, then the height starts to slow down, because further withdrawal of calories will lead to the child not attaining normal linear growth anymore. And so while the child may have been growing completely normally before this period of time, at some point then you will see a drop-off of the slope of first the weight curve, again that's an abnormal weight velocity, and then the height curve, a flattening out, a decrease in slope, falling off the growth curve. And it is incumbent upon us then, with a very careful history and physical, and select examinations based on what we see in the history and physical, to come up with the probable diagnosis that is causing the issue related to nutritional deprivation or chronic illness. But again, if we look at this purely from a bone age standpoint, which means if we feel we need more help beyond the history and physical, then as I said previously, the bone age is the best initial test, the best test overall, then we will find that once again we're in the category where, because this is something different, something not normal, the body helps us out by holding back on the bone age compared to chronological age. It is delayed, so that if we make diagnoses and if we institute the appropriate therapy, giving calories, correcting a chronic illness, treating a chronic illness so that the calories now can be used for weight attainment and height attainment, then what will happen is the child will start growing again, weight will come back, height will come back, and as long as there's enough time until eventual epiphyseal closure, and again because the bone age is delayed, then this child will have a significant amount of catch-up growth and may end up again being perfectly normal in the long run before the epiphyses close. The third major category in the division where bone age is delayed compared to chronological age with an abnormal growth velocity is growth hormone deficiency and thyroid hormone deficiency, in other words, hypothyroidism, the two major endocrine causes of this. And you can see here an example of a child who may have growth hormone deficiency, and beginning at 2 years now, and obviously from before that, the height attainment has been falling off because of little to no growth hormone. But you can see now from 2 years on down to when growth hormone replacement started at about 7 years, the slope falls off so that the line is almost flat. You would expect that to occur because there isn't any growth hormone. Well, if we then give growth hormone, you can see the rapid rise of growth again so that the child's growth curve comes back up to the normal growth curves. As long as this has been identified and treated well before the onset of puberty and certainly before epiphyseal fusion, then we have a significantly longer period of time where catch-up growth can occur. Again, by doing a bone age, you see why. This is the third category again. With an abnormal growth velocity, the bone age is delay. Again, let me point out that it's simply written in the reverse order. It says chronological age greater than the bone age, which means bone age less than chronological age, or the bone age is delayed. Now, in the history and physical of growth hormone deficiency, you will find nothing that will be helpful. This is a perfectly normal looking child. This is not the type of problem that we see generation after generation. It pops up sporadically, and so we simply have to think about this with the significant falling off of growth in the first year to 2 years of life, or we will not make this diagnosis and the diagnosis will be delayed. So this is the pattern that we see: a normal history, a normal physical exam, no family history, doesn't look like any other problem. You get complete falling off of the growth curve, flattening out, loss of slope, abnormal growth velocity in the first years of life, and then that has to tell you to test specifically for growth hormone deficiency. The other example is hypothyroidism, and in this graph you see acquired hypothyroidism. Child has been growing well prior to the onset of Hashimoto's thyroiditis, and then first has a problem with slowing down of the growth, and you can see that for a long time until the diagnosis is made and thyroid hormone replacement instituted, the child essentially has no further growth. It's important to realize in acquired hypothyroidism that the growth problem, slowing down, stopping of the growth, may occur prior, as is the case in this graph, to the onset of the typical symptoms of hypothyroidism that we're used to. The bottom line is, again, because the bone age will be delayed, that means we have more time for catch-up growth, and the best thing to do is make the diagnosis and start thyroid replacement as soon as possible. And if we do that earlier and earlier, farther away from ultimate epiphyseal closure, the best chance that we have then of having a child who will get back to about where he would otherwise been in terms of his adult height had this not happened. The remaining two graphs then are the ones where chronological age equals bone age, that is, the remaining for short stature. And this is the typical example, and the curve for this child is drawn over the entire life of this child from age 2, that is, until epiphyseal closure at 18 to 20 years of age. And you can see the characteristics. The child is short. The way it's drawn in this particular curve is he's just below the 3rd percentile, so you would have the true definition of pathological short stature. But the key feature is he is growing completely, utterly normally. He has an absolute normal growth velocity. From a historical standpoint, the key to making this diagnosis is finding multiple people within a family, or the tendency within a extended family history of finding not tall but short to average height people. Now, there can always be some exceptions from this. If there is any question, then you see a graph like this, and the history and physical doesn't suggest anything else, then confirmation can be made, again, by obtaining the bone age. And because this is a genetic issue, it's normal genetics, familial, that means the body isn't going to do anything with respect to that bone age, and that means the chronological age and the bone age will be equal. And as an example of short stature associated with genetic abnormalities, we have the very, very common Turner syndrome, again, a girl with short stature. Now, you can see by looking at the curves that the reason that the growth pattern in Turner syndrome, or for that matter, any genetic anomaly whereby we have short stature, which is the vast majority of genetic diagnoses, why the growth velocity is said to be abnormal is that the Turner syndrome curves, which are drawn on the bottom, are very slow ascending, more convex. They don't look anything like the changes that we see with periods of rapid growth, particularly in the adolescent growth spurt of the normal child. So qualitatively, the Turner syndrome growth, while the child is growing, is completely, utterly different than the normal growth curves, and for that matter, we'll say that this is an abnormal growth velocity associated with short stature. Because if you look at the end point, even the tallest Turner syndrome children are still, for the most part, at their end height as an adult, lower than the most of the shortest normal children. So, as with familial short stature, being that these causes of short stature are genetics, this time abnormal genetics, but nonetheless genetics, the body basically says this is the way it should be. And so again, this is the second situation where we have a bone age equal to chronological age. But it does turn out that there are some abnormalities in growth hormone and growth hormone receptors. And when we make the diagnosis of Turner syndrome, we actually do institute growth hormone administration because it can help with some mild growth at least, and perhaps move the child closer to the bottom of the normal childhood growth curves as opposed to being way below the 3rd percentile. Let's turn now to problems with feeding and weight attainment with respect to under and over nutrition. And the first set of information here simply has to do with an overview of some normal facts relating to feeding and nutrition. The normal newborn has adequate iron stores to meet requirements for 4 to 6 months of life. So whether the baby is getting formula for the first 4 months of life or is being breastfed solely for the first 4 months of life, we need no iron supplementation until 4 4 months of age. And now the most typical thing that we say, most common thing to do to supply iron at that time is to start the baby on iron-enriched cereals. Why 4 months? Because at 4 months, from a developmental feeding standpoint, this is the time where a baby should be able to take prepared cereal and take it off of a spoon, send it to the back of the mouth, and swallow it. Now, if you want to wait another 2 months until starting solid foods, that's fine, but then still beginning at 4 months, you need another source of iron, and perhaps that might be a multivitamin with iron, as an example. One way or another, beginning at 4 months, you need additional iron. While breast milk is very low in iron, compared to what is in most formulas, particularly iron-added formulas. The good thing about the iron in breast milk is it is much more bioavailable, meaning it will be absorbed better. Certainly a lot better than the small amount of iron that's present in cow's milk, grocery store milk, and therefore it is a cardinal rule in pediatrics never to make the switch from breastfeeding and or formula feeding until after the first year of life, that is to whole cow's milk from the grocery store, because of the low iron and also due to the fact that cow's milk in the first year of life can be rather harsh on the lining of the intestine and can wind up with some bleeding with further iron loss. All babies now need supplementation with vitamin D from birth. So formula is adequately supplemented, and as long as the baby is getting the usual quantity, normal feeding quantity of formula that a newborn baby and young infant takes, that baby will have a sufficient intake of vitamin D and it's not a problem. The problem comes in with breast milk. Breast milk is very low in vitamin D, once again just like iron, and so all babies who are exclusively breastfed beginning at birth need to be supplemented with additional vitamin D in a dropper form. No additional water or anything else needs to be given for the first 4 to 6 months of life. All of the nutritional needs then will be met with breast milk and or formula with the supplementation of vitamin D and starting iron in some form beginning at 4 months of age. The American Academy of Pediatrics always says that breastfeeding is the best feeding due to many reasons. The baby basically tells the mother when he or she wants to feed and how much, so it should be self-regulation and never forced for issues of overfeeding. Same with bottle feeding, of course. Why is breastfeeding the best? Well, here are some of the big advantages, the most important advantages. First and foremost are the psychological and emotional issues with respect to bonding. Breast milk has absolutely everything that an infant needs in the terms of the quantity of breast milk that's taken on a daily basis. Again, the only thing that isn't there is vitamin D and iron, but again, the iron for the first 4 months is not an issue. Again, the really important issue is the protective effects because of many immune issues with respect to breast milk. And so studies clearly show that babies who are exclusively breastfed for the first 6 months of life and longer through the first year of life into childhood have significantly less diarrheal illnesses, intestinal bleeding, spitting up, early unexplained infant crying, which we used to call colic, atopic dermatitis, other allergies, and certain chronic illnesses in general. Now, we can't say that every disease known to man is less, because breast milk is certainly not a panacea for that. But in terms of the immune protective effects, breast milk indeed is the best feeding. You should have a general idea of some of the contraindications to breastfeeding. One of the most important, if not the most important, is documented HIV infection in the mother. So in countries like the United States where there are safe formulas that can be made, then we will put those babies on formulas. Cytomegalovirus and herpes simplex if breast lesions are present. Hepatitis B, once the baby is vaccinated and has received a dose of hepatitis B immunoglobulin at birth because the mother is acutely affected, then the baby can breastfeed. If the mother has acute maternal disease, isn't fully treated, and the baby hasn't started on any treatment, then once again, breastfeeding should be delayed. The two big issues are active TB in the mother and sepsis. If the mother has breast cancer, the reason for delaying breastfeeding or not doing it is mostly because of the drugs that the mother may be taking, which can be secreted into breast milk. Similarly for substance abuse. So this table shows a little more specifics in terms of the drug contraindications, absolute versus relative, and you can see and look over the list of drugs on the left-hand side. The most important one, as was discussed in Chapter 2 on genetics, is alcohol, but all of these others are absolute contraindications to not breastfeed. And then there are relative indications to at least delay breastfeeding if the patient is on one or more of the drugs on the right-hand side acutely, until at least the mother has stopped taking these drugs. Formulas then are, infant formulas are used as substitutes or supplement for breast milk. However, one thing that we must never do is if a mother, for whatever reason, truly does not want to breastfeed, despite our education with respect to that, we should never make her feel bad about that because that can lead to extremely bad outcomes. So babies will do well on formulas in the long run, but as noted with breastfeeding, there certainly are the advantages present, and we always need to make sure that the mother is aware of those. The formulas, for the most part, are cow's milk based. That is, the protein is cow's milk protein, and there are various modifications made from one formula to another. The normal infant formulas are 20 calories per ounce, which is what the baby needs, taken in the usual volume per day to allow for adequate early infant growth over the first year of life. And as stated previously, for the reasons that I said, we don't want to introduce cow's milk, that is, make the switch from breast milk with or without formula until after 1 year of age because of the strong association to iron deficiency anemia. Solid foods may be begun at 4 months of age, beginning with iron-fortified cereal, as stated previously, but no other advancement of solid foods until 6 months of age. And then the introduction of appropriately strained baby foods, whether the family makes them themselves or you buy it in the grocery store, which can be often very expensive. Foods are started typically with the non-sweet items, vegetables, meats, and then added gradually fruits and dairy and meats. And the typical rule is you don't want to add a new food until about every 4 to 5 days, just in case there's some sort of problem with one of the foods. It's more easily determined that it's that particular food if we don't add too many foods at the same time. Gradually, over the first 9 months of life, the thickness of the foods, the chunkiness of the foods is increased. So you go from strained pureed foods to more typical foods that we eat, so that generally by 9 to 12 months of age, most infants should be on regular table food. One other little comment to make that we all learn about in step 1 is no honey in the first year of life because of the botulism spores in honey and the fact that in the first year of life during infancy the stomach acidity is not low enough to take care of those spores, whereas after typically 1 year of age we can. And so the introduction of honey for whatever reason after 1 year of age is okay. There's current controversy as to the introduction of typical allergic foods in the first year of life. Things like egg protein, wheat, fish and shellfish, chocolate, citrus fruits, and nuts. And what is being found more commonly in studies now is contrary to the old findings, and the old findings were always that we should avoid those foods in the first year and not think about adding them until the second year of life. But now it's looking like with a slow, at least cautious introduction of one or more of those foods in the first year of life, the long run shows that we may actually prevent allergies from developing. So this isn't absolutely sure yet. More studies are required in this particular area. A baby weighs 16 pounds at 1 year of age. Birth weight was 8 pounds. Parents state that the baby feels well. Physical exam reveals a baby with little subcutaneous fat, long dirty fingernails, impetigo, and a flat occiput. Now, as I commented with respect to the various growth charts, one of the most important ways of looking at problems with respect to nutrition is the body mass index. So just like the height chart, the weight chart, the head circumference chart, body mass index is calculated from 0 to 20 years of age. This graph again shows the body mass index curves from 2 to 20. And so we would calculate the body mass index, and depending on where you fall, you're either normal, you are undernourished, or you are overweight to obese. And for the time being, you can just glance at this chart and see where each of these points fall. So the problem of not gaining weight appropriately over a period of time is referred to failure to thrive. And there are two types, non-organic and organic. The most important cause, the most common cause, the one that we always have to focus on first, is called non-organic. This is not due to a specific pathology, a specific disease. In this case, the child is not fed adequate calories for any one of a number of reasons, usually many reasons together. This often involves very complex social, emotional, and psychological issues, interrelationships that are not correct between the mother and the baby, and things along those natures. In other words, again, not a specific disease, not a specific pathology. The clinical findings, nonetheless, show failure to thrive. The weight curve is going to be flattening out, and depending on how severe this is, you may get an emaciated looking child with very thin extremities, little subcutaneous fat, a very narrow, almost skeletal face, prominent ribs, a wasted buttocks, and a wasted appearance overall. But again, in the cases of non-organic failure to thrive, as was evidence in the vignette, we have some other ways of determining that psychological, emotional issues are the cause of this. Typically, the child is neglected in other ways. Their hygiene, they may be dirty, they may have recurrent bacterial infections, their teeth may not be cared for. They develop characteristic apathetic types of personalities. They become expressionless, little verbal output, little laughing, little smiling. Social and speech development is delayed, and they often develop feeding aversions, which also have to be corrected over time, in addition to very slowly correcting the caloric intake. The most important thing then in first evaluating a child with failure to thrive is, again, considering that almost all cases are non-organic failure to thrive for the reasons that I said, is to feed the child under supervision, under correct supervision, under medical supervision. That is, in the absence of the parent or parents feeding the child, and usually outside of the home environment. So we often may hospitalize these children, feed them in the hospital for at least a few days, if not a week. And if this is not organic, and if our history and physical shows no evidence of a specific pathology, that is, no evidence of organic failure to thrive, then under good conditions of feeding, these children should gain at least 2 ounces every 24 hours over the first week, and this documents then non-organic failure to thrive. And all of the issues with respect to what's going on now within this household, in the family, with respect to mother and child or even other family members, has to be delved into very completely and very carefully. Usually we find that once they start feeding and gaining weight, and once they get rid of any feeding aversions that might necessarily be there, they often have a ravenous appetite and want to eat and eat and eat. We have to be very slow sometimes in terms of allowing a certain number of calories because of certain dangers associated with eating too much in severe cases of failure to thrive. Observation of behaviors is very important, and again, along with the most important concept, which is feeding the infant under supervision as the major way to make the diagnosis. The corollary to this is what we don't want to do. So we want to delay extensive lab studies until after the dietary management has been attempted for at least a week, because then if you don't have an appropriate increase in a weight with good feeding, and then more likely you're going to have aspects of the history and physical that suggest another diagnosis. Under those circumstances, you can look at the honed in, based on your history and physical and laboratory studies, a possibility of specific causes of organic failure to thrive. So all cases caused by underfeeding from maternal neglect need to be reported to Child Protective Services. This is going to be a form of child neglect, which is going to be handled like child abuse. Now, less commonly, but the more important causes of organic failure to thrive are listed here. Malabsorption, particularly, can be due to many, many different causes, such as listed here. Allergies, severe allergies, gastrointestinal problems associated with food allergies can cause chronic diarrhea, vomiting, and failure to thrive. Certain immune deficiency states, but then we would also expect to see a certain pattern of repeat infections if that were the case, particularly with T-cell disease, or any one of a number of chronic diseases that may not have yet been recognized, as we talked about in evaluation of the growth curves, so that we first again have the fall off of weight, and then ultimately, if the problem keeps going on, the fall off of the growth velocity, that is, fall off of height attainment as well. So if this is the case, the most important initial diagnostic tests based on the most likely diagnoses to consider are simple screening tests like a complete blood count with differential, a urinalysis, even a urine culture, liver enzymes and liver function tests including total protein, albumin, bilirubin, clotting studies, and the use of the sweat chloride for any child who has chronic diarrhea, classic steatorrhea, particularly in association with abnormal changes in the respiratory system, which clearly, if you put all that together, suggests the strong diagnosis of cystic fibrosis, which is a very common presentation. We might also check the stool for various types of stool analysis to see if anything is being lost from a nutritional standpoint, carbohydrates, fats, proteins. We might check for chronic parasitic disease like chronic giardiasis, and most important again, you have to document the caloric intake to show that in the presence then of a child being fed well under supervision and getting a good amount of calories, which should be appropriate for growth, that child still is not growing, and that then suggests the strong possibility of organic failure to thrive. The last topic here is obesity, and this is a big problem, epidemic problem now in the United States, where about a third of all children in the United States are overweight to obese. The definition, if you saw that in the previous body mass index curves of overweight, is greater than 85th percentile overall. When we get to BMIs greater than 95th percentile of a child of any age and sex for the BMI curve, that's the true definition then of obesity. So the risk factors are predisposition to obesity, meaning families who are obese, families who eat poorly, a lot of calories, a lot of fat calories, have little physical activity, or for that matter, any medical condition which may lead to obesity. When we looked at the growth curves, we saw that for some tall children with normal bone age and normal growth velocity, they are tall and they are obese. So often we see the two of these things hand in hand. In that case, an obese child who is tall and growing normally, there's nothing abnormal with the height part of that. It's just absolutely normal related to the obesity. And again, we may find the same pattern of growth and obesity within families. We may also have an increase in adipose tissue in the mammary tissue in boys and the pubic fat pad, and this is particularly evident during the beginning of pubertal development, where it is more likely that overweight to obese boys compared to the ones who are not would develop what we call physiological gynecomastia. They may also have abdominal striae. So in summary, the diagnosis then of overweight to obese is based strictly on looking at the body mass index on the curve, not just a single value like you think about in adults. But the diagnosis is then for the appropriate sex, boy or girl, for whatever age, we have a body mass index greater than 95th percentile for obesity and greater than the 85th percentile for being overweight. There are a number of acute and chronic complications to obese children. In general, for the most part, we can make the observation that obese infants and young children correlate to obesity in adulthood. The most important in the long run, of course, are cardiovascular. We will talk further in endocrine discussions about the role of obesity with glucose intolerance and hyperinsulinism. We can have a purely mechanical effect of the obesity, particularly during rapid growth and endocrine changes in adolescence, and this is known as the slip capital femoral epiphyses, or SCFE. Children may have a lot of extra tissue around their neck and their airway and have obstructive sleep apnea, which correlates very well with weight, being overweight and obese, and type 2 diabetes, which again goes along with obesity, hyperinsulinism, hyperglycemia, and type 2 diabetes. The treatment in general is for the child to hopefully lose weight slowly and carefully under supervision, and that means a good accepted diet and carefully monitor exercise program. No medications for weight loss should be used in children.